Welcome to This Week in Critical Care. This week, we're covering 10 notable papers spanning septic shock resuscitation and the timing of vasoactive support, kidney replacement therapy and fluid management, and the evolving evidence base in hypoxemic respiratory failure and ARDS, plus 2 smaller studies that will change how you interpret blood cultures and prescribe stress ulcer prophylaxis. Let's dive in. We start with septic shock, where 2 papers pull in opposite directions on whether doing things sooner helps. In intensive care medicine, a target trial emulation using the MIMIC-4 and EICU databases asked when adjunctive vasopressin should be started once norepinephrine has escalated. Among nearly 4,000 adults with septic shock, whose norepinephrine reached 1/4 microgram per kilogram per minute or higher, the investigators used a clone sensor weight design to compare starting vasopressin within the first 3 hours against starting it between 3 and 6 hours. 28-day mortality was about 48% with the ultra-early strategy versus 53% with the later one, a risk difference of 5 percentage points, with a gain of roughly 1.5 days of survival time over the follow-up window and about an 18% lower hazard of death. Ultra-early vasopressin was also associated with roughly 1/3 less use of renal replacement therapy and slightly fewer arrhythmias requiring treatment, though not with less acute kidney injury. This is observational, built from electronic health records with all the residual confounding that implies, and adherence to the strategies was limited to a few hundred clones in each arm. But it is the best available signal that once you are escalating norepinephrine, the window for adding vasopressin is measured in hours, not half days. Contrast that with a cluster randomized trial in critical care medicine testing whether moving the whole resuscitation bundle even earlier, into the ambulance, saves lives. French mobile ICU teams delivered antibiotics up to 35 milliliters per kilogram of saline, norepinephrine for persistent hypotension, and hydrocortisone for norepinephrine-dependent shock, all within the first hour of pre-hospital contact. Among 381 analyzed patients, 28-day mortality was 22% with the 1-hour bundle versus 27% with usual care, and that difference was not statistically significant. Secondary outcomes were similar. The authors themselves point to enrollment imbalance across centers, and crucially, a small actual difference in care delivered between arms. The honest reading is that pre-hospital bundling did not reduce mortality here, and that speed alone, without a meaningful change in what is actually given, does not translate into survival. Moving to the kidneys, 2 papers reframe questions we thought were settled. In critical care medicine, a Japanese registry study of nearly 19,000 propensity-matched ICU patients found that, on average, receiving renal replacement therapy was associated with about a 6 percentage point higher hospital mortality. But a causal forest analysis showed substantial heterogeneity. Patients with markedly elevated creatinine, high blood urea nitrogen, and low urine output appeared to benefit, while those with relatively preserved renal function appeared to be harmed. This does not overturn the trials showing no benefit from early initiation. It suggests the average effect hides 2 populations, and that the discipline of waiting matters most in patients whose kidneys still have something left. The companion question, how aggressively to remove fluid once you are on continuous renal replacement therapy, is addressed in a 2-center European cohort of 973 adults across nearly 7,000 days of therapy, also in critical care medicine. After accounting for fluid balance, the net ultrafiltration rate itself had no independent association with 28-day mortality. Mediation analysis suggested the apparent survival edge among patients ultrafiltered faster was explained almost entirely by their achieving a more negative fluid balance, while more positive daily fluid balance tracked with worse outcomes. The practical message is that net ultrafiltration is a tool, not a target. Set a fluid balance goal for the individual patient and let the rate follow, rather than fixating on milliliters per kilogram per hour. Turning to the lungs, 3 papers together map how much of our ARDS playbook rests on solid ground. A registry cohort from 9 Toronto-affiliated ICUs in critical care medicine screened almost 22,000 patients and found that half of the cohort met criteria for acute hypoxemic respiratory failure within the first 24 hours, defined by a P to F ratio at or below 300. Of those patients, 76% required invasive ventilation, most received lung protective settings, and ICU mortality was 23% overall, rising to 47% among ventilated patients with severe hypoxemia. The point is that we are already applying ARDS-derived strategies to a much broader population than ARDS trials enrolled, which argues for a pragmatic, standardized definition of hypoxemic respiratory failure to anchor future research. On what actually changes mortality, a systematic review in the Journal of Critical Care identified 33 randomized trials and 23 interventions with a statistically significant mortality difference in ARDS, then compared them against the European Society of Intensive Care Medicine and American Thoracic Society guidelines. Roughly 3/4 of those trials showed a mortality reduction, and about a quarter showed an increase. Guideline recommendations backed by mortality-changing trials include low tidal volume ventilation, prone positioning, venovenous ECMO, steroids, and avoiding high-frequency oscillatory ventilation. But 8 interventions with a mortality benefit were not mentioned in the guidelines at all, and 5 further interventions were associated with increased mortality. That is a gap worth knowing about, both for research planning and for humility at the bedside. Steroids get a dedicated narrative review in intensive care medicine, which argues that corticosteroids in ARDS are best understood as context-dependent therapy. The evidence supports use in moderate to severe ARDS, particularly COVID-19 ARDS, and severe community-acquired pneumonia, but the effect is heterogeneous. Hyperinflammatory and septic phenotypes appear more likely to benefit, while data in influenza-associated and non-septic ARDS remain limited or conflicting. Long-term harms, including metabolic complications and ICU-acquired weakness, are still poorly characterized. And on getting patients off the ventilator, a meta-analysis in critical care pooled 23 studies and 2,000 patients with acute exacerbations of chronic obstructive pulmonary disease to test diaphragmatic ultrasound for predicting weaning outcome. Diaphragmatic excursion performed best, with pooled sensitivity and specificity both around 85% and an area under the curve of 0.92. The diaphragmatic rapid shallow breathing index was highly specific but less sensitive. The authors are appropriately cautious, mostly small single-center studies, post-hoc thresholds, substantial heterogeneity, and geographically concentrated evidence. So this remains an adjunct to clinical judgment, not a substitute for it. 2 shorter papers round out the week. In the Journal of Critical Care, a meta-analysis of 7 randomized trials and roughly 9,000 patients found that pantoprazole for stress ulcer prophylaxis cut clinically important gastrointestinal bleeding by about half, with no effect on overall mortality and no increase in ventilator-associated pneumonia or Clostridioides difficile infection. That is reassurance on the infection question that has dogged acid suppression for years. And a single-center self-controlled study, also in the Journal of Critical Care, compared blood cultures drawn from the central line hub during insertion against same-day cultures from other sites in the same patient. Cultures taken from the hub at insertion had roughly 2.5 times the odds of contamination, a finding robust across different matching windows. If you draw from a fresh central line, treat a positive result with real skepticism, and prefer another site when you can. If you only have time for one paper this week, make it the vasopressin timing emulation in intensive care medicine. It speaks directly to a decision most of us make several times a week, and it shifts the default from watchful escalation toward adding vasopressin within hours of hitting a moderate norepinephrine dose, with the caveat that this is emulation, not randomization. Here are the key takeaways from this week in critical care. First, once norepinephrine has escalated in septic shock, earlier adjunctive vasopressin, within 3 hours, was associated with lower mortality and less dialysis, while pushing the entire bundle into the pre-hospital phase did not reduce mortality. Second, renal replacement therapy is not neutral. The patients most likely to benefit are those with genuinely failing kidneys, and once on continuous therapy, fluid balance, not ultrafiltration rate, is what tracks with survival. Third, acute hypoxemic respiratory failure affects half of ventilated ICU admissions and is routinely managed with ARDS-derived strategies, several of which lack guideline endorsement, while others carry mortality risk. Fourth, corticosteroids in ARDS should be a phenotype and etiology-guided decision rather than a reflex. And fifth, pantoprazole reduces clinically important gastrointestinal bleeding without an infection penalty, while blood cultures drawn from a central line hub at insertion should be interpreted with real caution. That's your roundup for this week in critical care. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.